And we have begun. So we're going to continue today's unit. As you can see up there, we're dealing with respiratory. This is a continuation from where we left off. This is, you might recall, just to backtrack a little bit, that we were talking about the three factors, and we're just about done, that really played a significant role in respiratory air movements and our ability to really obtain proper pulmonary ventilation, allowing the oxygen and carbon dioxide to exchange. The factors have to do, is there any resistance? And that's going to lead to what's up on the board. Because although I can't demonstrate it today, I'll comment on that. We're going to talk a little bit about what are called pulmonary function studies and spirometry after we finish with this little review aspect. So we have airway resistance, anything that would limit the ability for the air to get through. We have surface tension, and again, to remind you, that was all about the surfactant, which we start to produce in utero at about 26 weeks of gestation, and that continues on through our lifetime, and effectively it's a wetting agent. And the wetting agent just basically allows things to be less likely to adhere to one another. It moisturizes it, if you will, and allows so they can expand and contract. But always remember, in the lungs, they're always inflated to some extent. There's always some residual air. And that's kind of like when I flip back here just a little bit. See if I can get to that one slide that's here. We went through all of that stuff. No, going forward. You might remember we were talking about the amount of air that was moving in and out. And if a typical, what we call the tidal volume, the typical amount of this pressure, if I went right by it, it's coming up, it's about a half a liter. And within that half a liter, about 150 milliliters of that is really air that it's not moving oxygen and carbon dioxide. It's basically there to fill the spaces. So that's part of it. I think we'll get to that graph ever so shortly, just to review it. And then the one we ended with was lung compliance. Now, you get the best analogy in the world, again, is when you want to blow, kid's birthday party, you're going to blow up balloons, you don't have something neat to blow up, you stretch the balloon. You're effectively increasing its degree of compliance. That's there. And again, I'm not dealing with the physics or things like that, per se. The resistance is what they talked about. Again, it has to do with, as it begins to branch, we have a lot. So any resistance usually occurs in the medium-sized bronchi. It's getting smaller, but then it has to do a lot with the total area that's there. It disappears when we get to what are called the terminal bronchioles. And at that point, we don't have to worry about it, because any air that is there is now simple diffusion is going to take over, and the exchange will take place. Remember, we demonstrated that graphically before. So additionally, all of these things, and this is what we're going to talk about with regard to anything that limits the ability for air to come in and out. And really, we focus on the bronchioles. The OLE suffix, we're at the point where it's so small, you either barely can see it or you cannot see it anymore. No, effectively, that's the implication. So with someone with asthma or anaphylactic shock, what happens is those passageways have such a small diameter and they're so flexible. The little bit of muscle that surrounds it, because the cartilage is disappearing, you have smooth muscle, and the smooth muscle responds to either the allergen or whatever the triggering thing is. And typically it's an allergen to either trigger an asthmatic crisis or a bee sting or exposure to nut oil, and something that will go into full-blown anaphylactic shock. What happens, that causes those mast cells we had talked about when we looked at the white blood cells to pour out. They're attached to that immunoglobulin E. Yeah, basically it's like this. The little dots is filled with mast cell or heparin, a little bit of heparin, but mostly histamine. Histamine is a very, very potent agent that acts on the respiratory system. So when we have allergies or hay, typically we take different kinds of antihistamines. Cetrizine, Zyrtec. In the old days, there were ones that made you drowsy. So here's the IgE that's sticking out of it, or the arm, sitting there, and that allergen contacts, it just bursts, pours out, pretty much the histamine. That will dilate blood vessels, fine. The problem is, all that increased circulation, what it does to the smooth muscle, is it constricts it. And so that's why we use someone with this problem as an EpiPen. Remember, we talked about that when we looked at the autonomic nervous system. We were looking at those beta 2 receptors. So we're going to trigger beta 2s. They will dilate the bronchial smooth muscle and allow us to breathe. And then you can take steps to deal with the histamine. You can use antihistamines. You can use steroids. That's the appropriate treatment. But that's why the EpiPen is so important. It all comes to this area that's there. And so I think that's something that was not around before. In my clinical practice over 25 years, only twice, we did not have EpiPens, but we always had an emergency kit, and in that kit was epinephrine. And epinephrine has different concentrations, but that particular epinephrine was there, and it just, only 2 times did I have an occasion where someone said, I was giving him an injection of local anesthetic. It's like, probably was a panic attack. Well, having trouble breathing, and I'm not taking any chances. And it's exactly what I did. I mean, so it's not something that's common. And that's why we're so cautious about that. Surface tension again, the alveoli get too small and they adhere. They're very difficult to separate. The surfactant allows or permits that to easily open and close, even though they're still partially inflated. Here it is. It's, for lack of a better term, it's a detergent. Not a whole lot different without the unpleasant taste of like a typical soap like a product. It's there. And again, this is the inflammatory respiratory distress syndrome that is, depending on where you're going, and hopefully you never have to deal with that. You might remember me telling you this is, do not produce adequate amounts of surfactant until the last 2 months of development. So, I mean, 26 weeks is the bare minimum. But now we make surfactant artificially. Natural and synthetic surfactants can be used. Different problems attendant we discussed, and here's the compliance. And that's kind of where we left off. How stretchy. Okay, normally it's high. Okay, between the surfactant, and if you go back and look anatomically in the lung, you'll see the alveoli, there's tiny elastic fibers. And so there's inherently stretchable. So it should be nicely compliant. And the easier the compliance, the easier it is to expand. So it's kind of a good news and bad news type of situation that's there. And they give you a thing, but this is really the interesting. Can be diminished by fibrosis, non-elastic scar tissue. So it loses its elasticity. When would this happen? Bronchitis, pneumonia, chronic respiratory irritation, smoking, environmental toxins. Okay, we would be remiss, given the area in which we are studying now, what this area was like 50 years ago. The steel mills right along here, not too far away. Ambridge, Aliquippa area, all the mills, all the trains, all the production. Neville Island in our backyard here, front yard, whatever it is. The atmosphere was horrible. I wasn't here. I was even a little surprised because it was starting to improve. The first time I came to Pittsburgh on a business trip with my dad was 1970. I think it was 1972. We flew in from New Jersey. I think it's the first time I remember being on a plane. So this is the type where you can see it. If we are no longer making surfactant, and then and this is a significant problem because loss of flexibility of the thoracic cage. This is when we do our final unit a little bit on aging. We begin to see these things. This is one of the problems with aging. You lose that. And indeed, some of the elastic tissue and some of the cartilage begins to ossify. We talked about that a little bit in advanced anatomy last time. So it's harder to expand. And it's different. Now, if you have somebody who's compromised because of lifestyle, environmental, occupational, previous infections, maybe cancer, anything like that. Now it just becomes an additive problem. So all of these things I'm talking about, if you didn't know, tuberculosis is making a major league uptick. It's what we call a resurgent disease. It's something we talk about in microbiology. and surfactant, lower lung compliance, etc. Pretty straightforward stuff. So all of these things play a role. And this is what I was talking about, ossification of costal cartilage, common in old age. No, it's not for me. See, this is an opportunity. What are you supposed to say when I say about old? You're supposed to say, no, you're not.
Not old.
So the major topic for today, I found one. I have to order more of these so we can at least get one willing volunteer. Okay, you can volunteer. But we're doing it in lab. And you get to show us how big your lungs are and how much volume they have. Effectively, we're going to measure something called your vital capacity. Forcing vital capacity, because we're going to force you to. Basically, you're going to take your deepest inhale and blow it out as hard and as fast as you can. You're going to measure really what effectively with vital capacity is the available space in your lung to oxygen.
That I test people that the doctor talks to them. They have to breathe in like
In
that,
their nose,
and then
nose clips. You're going to have nose clips. See, yeah, but you don't have big nose. It's easier to put the clips on. In the spirit of full disclosure, ladies and gentlemen, I have had a rhinoplasty.
are you serious?
Yes,
Did you break your nose?
7 different times. I had a deviated septum and all that type of stuff. I had a bad habit of getting into altercations. Did your mom, imagine your mom telling you this, hey Lou, go out, have a good time playing, don't get into a fight.
Did you win?
I won about as many as I lost. Didn't win them all. Muhammad Ali didn't win them all. So here they are. This is the volumes are used to assess. So we divide. Practice is called spirometry. So spirometry is short for respirometry. And the device we typically use is called the spirometer. Now it's done with electrical technology. You used to do it by displacing water in a drum. It's called wet respirometry because you're displacing water by the volume of air. This is a little bit different. So we know we can estimate based on your size, body type, different kinds of measurements. You don't do roughly what your total lung capacity is. And from that point on, you're able to check your respiratory status. The goal of the exercise, usually for people who have significant respiratory disease, you want to make sure that you have no obstructions, and effectively you can ensure that the, I'd say, maximum or optimum amount of air gets to the area to exchange. And the other one, when we talk about the other kind of disorder, is a restrictive disorder. And that means restricts, lowers the exchange. There's not enough available lung space, alveolar space, where the exchange actually occurs, for it to occur properly and sufficiently to support a reasonable degree of activities. So respiratory volumes are calculated. We have 4 different volumes, and when we add them together, combine them, we get capacities. Respiratory volumes and capacity are usually abnormal in people with these pulmonary disorders. And so we categorize them. Remember, physiologically, the conducting divisions from the nose to the terminal bronchioles. This has to do with how fast you expel it. There's a limitation of that, it's called obstructive. On the other hand, if based on what should be your anticipated vital capacity is diminished, at that point, we call it a restricted disorder. They can overlap. Emphysema is an interesting disease that overlaps. So you get little bits of both that are there. So the volumes and capacity are usually abnormal in disorders, it's barometer. Again, now we do it at less, and that's what the iWorks technology that we've used a couple of times is for. So sitting there comfortably, what you're breathing in and out is called the tidal volume. You don't even notice it. The only time you would notice it, or someone say, "Are you breathing funny?" And I don't think so, because we don't notice it. It's not under our control, really. We have almost like a little metronome inside that basically governs the speed of our breathing, unless we electively try to change it for it, to hold it longer or make it greater. And that's average about half a liter. You always have a greater degree, even after you normally would inhale, of inspiratory reserve volume. Try it yourself. You can take a really deep breath compared to how much you have to blow out the candles. That's your expiratory reserve volume. How well you could sit there and just out of nowhere, without taking the deep breath like you would if it was your birthday, and just start from there. You can't do it quite as much. So and I mean, statistically, it's probably a good 2.5 times more. So the inspiratory reserve is this. And notice in a normal individual, that's 3 liters. There. That's pretty substantial. Your total lung volume is probably between 5.5 and 6 liters. The expiratory reserve, you can see, is proportionally less. Okay, and I can't, again, and through the full disclosure, if you smoked 2 packs a day for 40 years, you wouldn't have a very good job blowing out the candles. And remember, May 10th, how many candles are there going to be? That's right, 76. One of them is for good luck. So if we bring in a cake, I expect a lot of help with those candles.
May 10th, we're not even here anymore.
Well, that's Mother's Day. We'll have it on like the Thursday before, whenever when our final is, I'll get a cake. And you can put those candles in. No cake for you.
Why? I like red velvet.
I give up. That's why I knew I had problems when my first marriage. My first wife didn't like chocolate. I mean, immediately then that was a problem. She's okay. She still doesn't like chocolate, but she's okay. And so let me show it to you without talking about it. It's easier to do it graphically than go through all this stuff. And it's not something necessarily you're going to have to learn and say this. I'm more interested in whether it's obstructive or restrictive and what that implies and what those are, rather than say, oh, the functional reserve capacity is the sum of residual volume and et cetera, functional residual capacity, vital capacity. And really the big numbers are here. So this is the way you typically would look, and we can mimic this to some extent, okay? And effectively, this is the tidal volume. It's usually about 1/2 a liter. And so for this particular individual, I think we're looking at around 5,500 total volume, total milliliters. So up here, if you would take your deep inhale, your inspiratory reserve, they're looking at 6 liters. There, here. And then on the other side, if you brought it all the way down, after the tidal volume, you had the expiratory reserve volume, you would have to take it down with only about 1,000 of what's called residual volume. Residual volume is the amount of air that are in the lungs, continue the entire lung. It's a massive amount of tissue, basically to keep it, relatively speaking, inflated. It increases with something like emphysema. And then remember the name, what emphysema means is not a respiratory disease, it means trapped air. And it means you've trapped air that isn't, so it actually increases. And so we have what are called anatomical dead space and functional dead space. I mean, if you've had pneumonia previously, it increases. If you, like me, have a bad history of smoking all those years, it was almost kismet. I stopped smoking June 20th of 2008, and I started teaching here that August. So my health is because of Robert Morris. So, yes, ma'am.
Is it possible for a human to exhale voluntarily and collapse their lungs?
You do not think so. I assume it, the word possible tells you always have to say yes to that. Just can't imagine. just think this, you get to the point where you could because you're blowing off so much air. All of a sudden, it's like sort of the opposite of the little kid said, I'm going to hold my breath until I die. You're going to be sorry for throwing a tantrum. Go ahead, knock yourself out. Because what's going to happen, they hold their breath longer than they're going to faint. I think it's sort of like the reverse. So, I mean, that's the way I would think. Short answer, I'm not sure. I mean, it's worthwhile looking to see. I think you're more likely to hurt yourself if you were predisposed to a stroke or a heart attack. That would be an underlying disease. I think that's a more reasonable explanation. Okay, so here they are. So you can see the numbers that are there and what they are and how do we go about doing them. Okay, we use basically in the lab, we do this. The difference is, and that's what I was saying before, I know you might do that test in the office, but when they do it, particularly in sport, which is where it really is, it's gone a long way. The first time I saw it used, and it's tragic because the man who was using it probably never had to do what he did to be successful. And that's the cycling, because cycling does it all the time. Lance Armstrong. Lance Armstrong, if you did not know, was a world-class cyclist long before all the scandal. He actually had testicular cancer and metastasized to his brain. He recovered from that, okay, and was still a world-class cycler. Why they had to do the blood doping, spinning down blood and retransfusing it themselves, I don't know. I mean, it's just tragic that somebody who's probably could have won some Tour de France's on his own did that, but that's a whole other discussion. But that, I mean, I saw them in his training films. Those clips, exercise bike, breathing in and out of this tube, no way for air to get in and out, trying to do things, mountain training, all the type of stuff that you could do on any kind of exercise, but the more modern ones we have today. So here's the space. This is the chart I was looking for before. At the very least, about 150 milliliters of that 500 is dead space. Okay, and we have a lot of different things. They could be alveoli, the little chambers where the exchange takes place, and then we add up all the different, whether it's anatomical or alveolar dead space. And so what we're going to be looking at with this is the distinction between obstructive, anything to resist, chronic bronchitis, a mass, potentially, some structural abnormality. If we add them, the total lung capacity, okay, and basically what we're able to do, all of these may increase. The forced reserve, the reserve volumes, all of these may increase because of hyperinflation of the lung. So obstructive is just that. There's too much resistance. Restrictive, reduced total lung capacity due to the disease. Tuberculosis, environmental agents, and again, emphysema kind of overlaps. And you can look at all of these. The key is to understand how they come along and we find them. And these are the two measures. The forced vital capacity, simplistically, is take your deepest breath all the way in and blow it out as hard and as fast as you can, just like I was telling Jennifer. That's your forced vital capacity. We measure that. We have an idea based on measurement, general body type and measurements, what the total lung capacity is, age, physical condition, etc. What that would be, and from that point, we determine what your normal vital capacity would be. If for some reason you're blowing out less, that suggests a restrictive disorder. You do not have enough viable lung space for the exchange in the exchange division. All that area, when we're close to the alveoli, we're close to the capillaries where this will exchange. Now, that volume over that specific time, we measure what's called FEV1. That one isn't 1 minute, it's 1 second. You should be able to blow out 80%. And this is one of the things that's great with the technology because you kind of get where the peak is and where the trough is and get an idea from where the person started and roughly ended, and you go about 80%. And bang, you see that almost all the time it's right around a second. Sometimes even faster. And so a healthy individual like all of you are will be able to expel 80% of this forced vital capacity in that first second. Obstructive diseases exhale less than that, whereas those with restrictive diseases even increase it. It's interesting. Obstructive, basically, an obstructive disease, what you do with your lung, there's something blocking, so you're struggling to pull air in, and you tend to get bloated. It has a lot to do with body type. And so they can't get air in, and if they're built like I am, okay, we call them blue bloaters. They're big chested, wide, broad, and they're not getting air in, so they look blue. They're not well perfused. Their color looks terrible. On the other hand, with emphysema patients of another type, when we see restricted, we call them pink puffers. They've got so much air in there, they have very little ability to expand, so they're puffing. They can give a pretty good puff, proportionally speaking, but they're almost retaining oxygen at times. And it gives sort of a pinkish hue. It's interesting, it's phenomenal. But generally, this is the way we look at these things that are there. And so if you go back, and they should have it. So we are taking a look from peak to trough, so to speak. And, we can put the markers here and here, figure out the time, calculate 80%, bring it over, and you'll be able to see roughly how long it been, if it was indeed a second. So that's really what I've tested students over the years with the barrel and the water. I mean, one guy who's so physically fit. I mean, he I don't know how he did. He moved the better part of 6 liters. I mean, he just had great lung. Good sized guy, very trim. I mean, he worked out. He told me he worked out basically 6 days a week. Nice, very, really nice guy. One of my early nursing students when I was teaching over at Jack. And so here's another one that's interesting. So the total amount, typically in a minute, the minute volume, probably, let's say for the Model 6, 5.5 to 6 liters a minute, that has to match cardiac output. We call it cardiopulmonary resuscitation for meaning, for appropriately meaning that, because your heart can only function if your heart is moving 6 liters of blood. You need 6 liters of air to oxygenate it. If there's any imbalance, it's a horrible cycle. If your lungs are damaged, like mine probably were, but I've thankfully recovered, you're not getting enough oxygen in. Your body reads that. Your hypothalamus goes, I'm not getting enough oxygen in. It sends a signal by way of the autonomic nervous system to your heart. Speed things up. Not getting enough oxygen. The heart speeds it up, has to work harder, but at the same time, it's pushing the blood through the lungs. The lungs aren't very efficient. They're not getting through there as fast. Basically, the message, I still need oxygen. What are you doing down there? Speed up the heart, vicious cycle. The harder the heart works, the more difficult it is to get oxygen to it for the increased workload, and therefore, finally, it fails or has a heart attack. And so, I mean, that's the tragedy of it. It's extraordinarily difficult and very difficult to deal. It's part of what I have alluded to before. We call multi-system failure. One affects the other. Now the heart doesn't work. Now the next thing your kidneys are going, I don't have enough blood pressure to work, so I'm going to shut down. And now you're in trouble. So all of those things. Now with exercise, appropriate training, look what you can do. Increase this by maybe 30 plus times. That's what they were demonstrating when I was watching these videos with training sessions with Lance Armstrong. I was very interested in that. I mean, I know about you. I love watching. I've never been there. I love watching Tour de France and see all the people cheering on the sidelines and the wonderful scenery and how they're going up hills and down hills. I just love it. So, and it's only an estimate. Okay, this is the ventilation rate in and out of the alveoli at appearing a particular time. Much better indicator. And so they give you the numbers that are here, the milliliters per minute and how frequent and the dead space. The best way to show you is this, okay, where rapid and shallow breathing can actually decrease the ventilation rate. This is a graph that's worth better than the way they try to express it on that particular power. Normally, average, you and I, 12 to 20 breaths per minute. Normal respiration relies. For argument's sake, because it gives us a nice and round number, we have a tidal volume of 500, 20 minutes. Remember, the There's 150 of that is dead space. It's not moving oxygen, carbon dioxide. So our efficiency at that point is 70%. Fine, we're doing good with that. If you're hyperventilating, somebody's really excited, rapid shallow, let's say you double the rate, you reduce the volume because you're going so rapidly, you're reducing the volume, tidal volume, you get the same 10 liters, but you're only 40%. Now, if you tell that person who's hyperventilating, okay, slow, deep, you have to mimic that, and you try to demonstrate so they can breathe along with you. And it doesn't matter whether you're in a medical field or not. It could be just somebody who's excited about something, panicking about something. Maybe you can help them. You get a paper bag. You know, you breathe it through a paper bag. Basically, you're replenishing the carbon dioxide because they tend to get alkalotic, and you want them to get more of the essence of something. That's the idea. We'll look at that. So, slow, deep breathing, cut the normal rate extensively in half. Same now, look at the volume that's there because you're taking deeper breaths. 85% effective. That's pretty darn good. I mean, you'll make it through the next day, I hope. You see what I mean? So when we talk about the exchange of gases, this is the other part. When we start to look at the numbers. So if I say to you, and I throw out the question, we all answer the same way. We exchange pretty much equally oxygen for carbon dioxide, right? One oxygen in, carbon dioxide, go through the membrane, simple diffusion. They share a membrane. If this was very, very tiny and thin, you'd have the lining cell on either side. The interesting thing is there's different concentration gradients because it's not just about concentration. It has to do with solubility. That's the other point. So in this book, I call it breathing or respiration, but they call it external respiration. I'll buy that. Internal respiration, they're talking about the cellular level. And these are some of the things, these are sciencey things. These are, I don't know whether you do them in chemistry or not. You probably do. Okay, Dalton's law of partial pressures, right? Is that a name you've heard before? Okay, and basically we all know what it means. We can use partial pressure of gases to represent concentration. That's all. And we know what we basically live in an 80-20 environment. So that's 760 millimeters of mercury or 1 atmosphere, roughly 80% nitrogen, 20% oxygen. We Star Trek people call it Class M planet. Doesn't help. They don't know. We have a Class Robert Morris planet. And little bits of this, carbon dioxide, water vapor, other gases, changes at high altitudes, partial pressures decline, with the lower altitudes underwater, partial pressures increase. And they show you the numbers here, and I'm not worried about the chart. A different law for gas mixtures in contact with liquids, plasma. Each gas will dissolve in the liquid proportional to its partial pressure. Okay? So the amount of each gas dissolved, carbon dioxide is 20 times more soluble in water than oxygen, and little nitrogen will dissolve. As temperature rises, the solubility decreases. Okay, interesting. Okay, and now I'll get to the hyperbaric chamber. So first of all, understand carbon dioxide dissolves pretty well, and that plays a role when we start. Remember, we've talked endlessly about the same thing, that carbonic acid buffer. The single most important buffering system in our bloodstream. Water and carbon dioxide, carbonic acid, reversible, etc. We'll go over it yet again. Hyperbaric. What's a hyperbaric chamber? Yes, ma'am.
I actually just looked that up. It says it involves breathing 100% pure oxygen into a pressurized chamber, raising air pressure 2 to 3 times higher than normal to boost blood oxygen.
Why would you do that?
Said it's used for conditions like chronic wounds, carbon monoxide poisoning, and decompression.
Decompression chambers. They'll use compressed air. The typically they'll increase the oxygen. So this whole idea has to do with anybody here a diver? So divers, scuba divers, have to be aware of something called bends. Did you ever hear that expression? Okay. So again, in full disclosure, my first weapon is first. So they're very familiar. So what happens is you're going down. Let's see, my son was trained to be an underwater whatever. At one time, you get the course CCAC 7. I end up going what happens is if you're down for a period of time, you can't just come up. You can, but you're running into a problem. You're down at depth, it pushes more nitrogen into your system. Nitrogen goes in, the deeper you are, the longer you are, even if you're not that terribly deep, the longer you're there, there's a whole schedule. If you come up too fast, the nitrogen comes rapidly, it doesn't go in very well easily, the pressure does, it comes out and forms big bubbles. Those big bubbles, potentially lethal because they obstruct blood flow, vital organs. Then you get into double overpaying, hence the name. So, decompression chambers, they mimic it. You came up too fast, a line blew, there was an accident down there, there wasn't somebody handy to give you, you didn't have another spare tanks to go down into the decompression chamber.
So the nitrogen comes from tanks.
No, it comes from the nitrogen in the air normally. So the nitrogen, rather than valid point, they do, moreover, when they have sustained divers, which are really very, very deep in the ocean, they use mixes. They use a mix of different gases to prevent that as much. Then it may come from the air, the tanks, and not.
So there's no reason nitrogen increase inside of this water.
And you already, the
So
nitrogen's already
they
there.
don't create like huge bubbles.
And it pushes the nitrogen in. When you go too fast, they come down.
Like you rub this inside.
Yes, conceivably, the rupture of blood
Does
vessels.
that ever happen?
Don't know. I do not. But now you get bends. You're doubled over. So what you do is you tell them, basically they take these people to a nitrogen, to a place where they have a decompression chamber like a ship. Dive ship would have that. You're in there, and you're in there for quite a long period of time. The other thing with oxygen, I'm aware of this because we use it for wound healing, and I have a background in that. They use hyperbaric oxygen for burn. There's a great movie, maybe with the late Patrick Swayze, called Factor, some years ago, about firefighters. You'll see him, and it looks like a plastic coffin. And they put them in there because they give them hyperbaric oxygen. Carbon monoxide, and this is part of the unit, carbon monoxide is a remarkable agent that attaches, it's more, latch onto your hemoglobin almost universally. You almost can't break it off. It's a much better fit. So what happens is, the whole idea for carbon monoxide poisoning, blood cells have a lifespan, remember they last from 90 to 140 days. The longer you keep somebody alive who's at risk of carbon dioxide poisoning, with that this hyperbaric oxygen, you force out what you can, but you completely oxygenate the other cells. Every day is a win. After a week or so of doing that, so I mean, there's a lot to that. And we used it for wound healing because a lot of diabetics have low oxygen anyway. So there's so much of this stuff that's interesting and fun, I think. So breathing oxygen in 2 atmospheres is not a problem, but you heard what Abby was saying, at 2.5 to 3 atmospheres, it can be a problem. And here's the thing, free radicals. So we have to deal, I think you have to be aware, and I am unaware. This is probably more of the times when you have to have somebody in an oxygen chamber. You cannot put infants into them if they're born with poor oxygenation. It has a really hyperbaric oxygen has a really damaging effect on their eyesight when they're very young. That's my understanding, unless that they've changed the technology. So it just, these are offshoots of respiratory physiology. So alveoli contain more carbon dioxide and water vapor than air. Oxygen out of the lung, carbon dioxide diffuses into the lung, humidification, mixing the gases. And the neat thing about mixing the gases, air that was left in, mixes with the other gases. It's not as though it's stagnant. Might be the way to describe it. This is the idea of how it exchanges. Partial pressure is concentration. Simple diffusion 101. Nonpolar covalent small molecules pass through the membrane easily. Thickness of the membrane itself is very narrow there. Ventilation and perfusion coupling. You recall Monday, and I won't be able to get all this in today. This is the two-edged sword. We couple the area where we have the best ventilation available with an area that has the best blood supply. So when lungs are damaged, it's a safety mechanism to shunt deoxygenated blood in the pulmonary vessels, coming from your heart to be reoxygenated, to an area where it has the best perfusion. Our body will intentionally dilate bronchioles to allow it to flow that area, and it will recognize the areas where there's the best perfusion, the best blood supply. That's the good news. The bad news is, as you begin to lose lung tissue, if you continue to smoke, if you have recurrent pneumonia, if you have damage to your lungs from something else, eventually, like I told you, that's that person who goes in, I don't know why, I was just trouble breathing, doc. Every time I've been here, you gave me the antibiotics. I got better. Of course, I'm still smoking. And they go, you're going to have to be on oxygen for the rest of your life. It's like, Matt, but I didn't yesterday, but today is different. You've hit that tipping point. The body has a number of those. The kidney has another one of those. Partial pressures and gradients, gas solubilities, etc. So this is what I was telling you before. We have a couple of minutes left. Okay. And you can begin, the idea is the steep partial is oxygen has a large gradient. And it only takes about a quarter of a second, and blood has 3 times that much to pass through those capillary beds. That's a built-in safety margin. If things are going a little slowly, who cares? I mean, adequate oxygenation, the blood flow increases by it. So if you're moving more blood, you have that wiggle room. If it's moving a little slowly, you'll have plenty of time to get through. And you'll notice the gradient is a little bit different. So the CO2, you're talking about 5 millimeters that are there. And so they'll show you, the reason is that carbon dioxide is 20 times more soluble. And I think this is a PowerPoint error. Okay, venous blood PO2, the alveolar oxygen is much higher than that. It's not equal. You'll see the numbers. I can't do it here. I apologize. Here, your PO2 is about 100. Okay? Sit there. So you're using 40 versus 100. That's concentration gradient. 40, 45 versus 40. That's concentration gradient. But obviously the side with the 60 millimeters of mercury difference. So why is it equal? Why do our oxygen and carbon dioxide effectively move equally? They move equally because carbon dioxide is 20 times more soluble. So solubility is critical. It just traverses the membrane more easily. It's more compatible with the environment, with the phospholipid bilayer membrane. Pretty good stuff. I mean, I didn't want to go too far. I had seen that error before with regard to the PowerPoint. You can blow this up. I'd have to do it differently to see it, but I think you get the idea. And so look at this. In a quarter of a second, your blood is reoxygenated very, very rapid. Look at the distinction that's there. It doesn't take very long for that to occur. So, I mean, I constantly like to tell you about these built-in safety margins, these built-in redundancies, all this available space. But we'll talk more about it next time. Thank you very much. We'll call it a holiday. Let's thank Dr. Badger for joining us today. Because with him here, you guys are always on your toes.